we are now reaching the final session of the day, a conversation that connects everything we've discussed so far. After exploring innovation, data, and resilience, this session asks a key question. How can we move from strategy to action, from policy design to implementation on the ground? This roundtable will bring together regional and national perspectives to identify the levers that can help scale what already works in digital health. To guide this discussion, please welcome our moderator, Maddalena Illario. She is the president of the Regional Sites Collaborative Network. Benvenuta. And the panelists, Petri Lehto, Ivan Chorbev, Ana Maria Carriazo, and Karina Dantas. Welcome, a big applause for all of them. As for Maddalena, she's a medical doctor, researcher with long-standing expertise in digital health, integrated care, and innovation ecosystems. She has led numerous European initiatives bridging science, healthcare delivery, and policy implementation, always with a focus on citizen well-being and sustainability. Thank you, Maddalena. Grazie mille. You have 1 hour.
Thank you so much. So thank you, everybody, and thank you for staying despite the long day. So this session, as our Master of Ceremony just referred to, will be focusing on turning European ambitions from strategic vision to practical implementation. And we have been learning how strong and visionary are European foundations in terms of digital health. The digital decade calls for a more resilient, innovative, and inclusive digital Europe by 2030. And European health data space is one of the most concrete and transformative steps towards the implementation of this vision, empowering citizens with secure access to their health data, enabling care, and unlocking new scientific and technological breakthroughs. But we have been learning also today that policies, as important as they are, they do not transform healthcare alone. What truly changes life is implementation. When a nurse has the right information at the right time, when a researcher can turn trusted data into a life-saving discovery, when a startup can scale a solution that reduces waiting times and improves quality of care, and when a citizen can feel supported and in control of their own health journey. So I think that digital transformation embodies the most important European values like equity, ensuring that rural communities have the same access to health and social services than a European capital. It is about sustainability. We have learned that we can make our healthcare system more sustainable through risk stratification, and we can improve well-being of the citizens. So today, let's dive into this session with our experts. We have representatives from the national level, Petri Lehto, Senior Lead for Innovation at SITRA, Finland's Innovation Fund, bringing insights from Finland policy ecosystem. Petri has been at the forefront of national digital health and well-being initiatives, helping to translate Finland's digital strategies into scalable, people-centered solutions. His work focuses on ecosystems that combine innovation, public trust, and sustainable digital infrastructure. Then we have the regional level, Ana Maria Carriazo, Senior Advisor at the Regional Ministry of Healthcare, Presidency and Emergencies of Andalusia, who will share how the subnational level can shape policy at regional and national level. Ana Maria has extensive experience in European health cooperation, research, and cross-border innovation projects, representing Andalusia in multiple European networks in the e-health stakeholders group, Vice Chair of the Reference Site Collaborative Network, Chair of Euro Coalition. Ivan Chorbev, Ivan is one of the leading experts in digital health. He's a professor at Faculty of Computer Science and Engineering at University of Skopje in North Macedonia. And Ivan is the head of software engineering department at UKIM, specializing in machine learning, e-health, and assistive technologies. He has led numerous EU-funded projects on digital innovation and ICT systems for health and education, bringing a technical and academic perspective to scaling digital health solutions across Europe. And then we have Karina Dantas, CEO of Shine to Europe and leader of the Maya project, highlighting how inclusive, community-driven innovation can turn European digital health policies into sustainable practice. Karina is an expert in social innovation and digital inclusion, leading a European project that translates digital health policy into accessible, community-driven practice, and their work has been championing for, I think, the past 20 years or something, co-creation with citizens and ethical frameworks for the adoption of new technologies in health and care. So join me to welcome our experts. And I would like to break the ice with a general question about your perspective. And usually I don't start with tech-driven approaches, but today we do start with Ivan Chorbev. So Ivan, could you give us a short overview of which technologies we have available that are mature enough for implementation and how we can use them in the healthcare and social care systems? The floor is yours.
Thank you very much. Thank you for having me here. It's a pleasure and a very educational event for me. So it is true that science has evolved quite significantly, especially AI and different flavors of AI that are being utilized in the medical domain. The thing is that those experimental or advanced pilots or even proof of concept applications don't immediately automatically translate into implementation tools in the hands of doctors. We face this so-called implementation gap that we develop something, but then either really slowly or it never materializes into actual tools in the hands of doctors. So of course, what we now know as AI is not the first AI tool. Now we talk about these generative AI large language models, but even before that we had deep learning, we had image processing tools, or we had natural language processing, machine learning, of course robotics and computer vision. And its applications vary in almost every domain. When I talk about image processing, we have integrated tools in radiology, in the MRI machines themselves, in the ultrasound machines themselves. For instance, my research team has been working in collaboration with an American startup to implement automatic ejection fraction and blood clots in the heart without doctors having to view the ultrasound. So the algorithms analyze the ultrasound images and they can calculate the throughput of blood through the arteriostenosis if it exists and so on. Also, we have natural language processing and large language models to make some chatbots to discuss with patients in psychology. We have generative AI used to reprocess the diagnosis and show them to the patients. Of course, image processing also involved analyzing cells in pathology, and so on and so forth. But the main issue we should tackle is the fact that we succeed in the laboratory with our experiments and then that does not translate into implementation. So why is that? First and foremost, in laboratories we work with cleaned data sets that are limited in size, they are more or less structured evenly, and they come from a single hospital or somewhere. In the real life, every data set is different. Every group of patients is different. The structure of patients is different. So when the science hits the reality, not all things go as planned. So what we need is, for instance, this European health data space should promise easier availability of integrated data sets that will be much better input in the creation of models to avoid overfitting, to avoid neglecting special rare diseases that only show up in certain regions. You know, even in Europe, not being that big, there are different Mediterranean thalassemia compared to different diseases in Northern Europe and so on and so forth. So data sets used to train models in Finland might not simply apply to Southern Europe. Therefore, we need another aspect, which is making data much more available to researchers through standardized, secure, safe, and anonymized access to this data. Another barrier to adoption of the systems is the lack of explainable AI. So the doctors and of course the patients need explanation why the diagnosis is such and such. So if the AI tool just throws an idea for a diagnosis, stating certain probability of correctness, that's not enough. We should work more on explainable AI so that the physician can read through the reasons why the algorithm is proposing this diagnosis rather than just a black box, a machine that you cannot really trust. And of course, the final barrier for adoption is the complications of the user interfaces and adding extra layer of complexity to the anyhow complicated life of doctors. So tools should not be an extra work. They should integrate within the workflow. So these tools should ease up the stress and the workload on doctors rather than adding extra bureaucracy and complexity. So these tools should be seamlessly integrated into the machines they use, into the tools they use, and you know, if you get the input from the MRI about certain ideas the algorithm gives you, you should easily translate that into the hospital's information system to be stored in the patient's personal file. We shouldn't manually type it. A printer should not give me a paper that I should manually retype again and again and again. So user interfaces and seamless integration and even reforming the workflows, adopting the new workflow that is reflecting the new reality.
Thank you, Ivan. And that brings me to Anna, because you have been referring to the organizational impact of new technologies. So, Anna, in the light of what Ivan has just been describing, how do you see the current organizational frameworks in terms, for example, of integrated care, considering the different European healthcare system and the regional levels?
Thank you very much, Maddalena. It's a pleasure for me to be here and to provide some insights from the regional level in which we are responsible. As you know, the different member states in the European arena are not exactly the same shaped and organized. In the case of Spain, and it has been mentioned before, and in other countries, healthcare and public health is a regional competency, and we have the responsibility for providing healthcare and public health services to the entire population in an integrated way, from health promotion, disease prevention, treatment and cure, rehabilitation, and palliative care. That means that we have to be aware of all the full spectrum of different kind of settings. And in the case of regional services, particularly in the case of Andalusia, we have been working and implementing electronic health record for a number of years now, more than 20 years, and in an integrated way, because it's the same service, including hospital care and primary health care. Changing the way of working of health professionals in the system is not an easy task. My region has more than 8.5 million inhabitants, and the healthcare workforce, including all staff, is more than 120,000 professionals. So changing that system is quite different. It's like moving an aircraft carrier in a different direction, so it takes a while. But I think that having a digital strategy digital health strategies, basic. And within Spain, we have quite well organized the way these research solutions can get into the current workflow in the healthcare providers. First, we need to have easy label, and then you have to go through health technology assessment and provide that those are safe and secure to be used. Within the research area, there is no problem, and then you have to move it into the real world, as you said. And usually, I think there are ways of including that, particularly when you have at least design, or I was going to say well-designed, but at least design health strategy, addressing digital services, how to include them. Digital transformation is not doing the same thing, but with a computer, but doing things in a different way that it makes the life of professionals and of patients easier, and fostering innovation in the system. For doing that, I think that there are 3 lines, strategic lines that have to be followed. A good governance, it has been mentioned at European level, at national level, we have there is a strong conversation, let's say, between the different regions in Spain, the 17 autonomous communities, as they are said, as they're called in Spain, and the national level, together with Europe, have the right skills of professional capacity building, and also never lose the sight of the human being, the humanization, because you have to provide health services, digital services with this lens. So there is a path, there is a way to do that if you have the right strategy and how to put new services and try to improve them in a continuous way, to improve quality and to provide integrated care to the entire population.
Thank you so much, Anna. And you mentioned that a number of changes need to be implemented, and this digital health is a dynamic element. It's dynamic because technology is developed much faster than we can implement, and it's dynamic because the regulatory framework is evolving. So I'm asking to Petri, the current regulatory framework, and how does the human in the loop come into play? Because when you talk about organizational frameworks and we want to integrate solutions, someone has to take responsibility for it. What do you think about it?
Yes, well, first of all, great to be here. Just a few words about SITRA, because you may wonder what the heck is SITRA. It's not a ministry, it's a kind of a think tank in Finland. We report to the Parliament of Finland, so owned by the state and government of Finland, but we are independent from the government in the sense that we have an endowment on which we live on. We fund societal innovation in Finland, work in a few specific areas. Health has been there for decades, actually, and for the past 10 years we have been working on health data. And this we have been doing in Finland together with the Ministry of Health, but also with the local players, the healthcare counties. We work domestically, but also at the EU level, we are coordinating at the moment the so-called EHDS TEHDAS 2 work. We did that for the first one already, so meaning that we are there quite deep in the health data domain. Now, when it comes to AI and the regulatory perspective, we piloted last year the use of AI with the healthcare counties in Finland quite extensively. We focused on the patient medical record documentation domain, meaning that it's very close interaction between the patient and the medical doctor. And certainly one of those areas where it's been thought that can be providing great savings, or in other words, great productivity gains, because there is currently so much of manual work in that line of work, which is happening before the patient comes to see the doctor, at the time when the interaction takes place, and then after trying to come up with the diagnosis and then placing the data to the patient information system. So there's lots of manual work. In Finland, actually, the ministry went through quite an interesting study last fall, which was about trying to calculate how much of time do the healthcare professionals, especially the medical doctors, spend each day on this manual work for patient medical record documentation, and it was really astonishing, because it was more than 40% of the time each day, 3 hours and 14 minutes. So that's really quite dramatic finding, I think. So in that setting, whatever we can do with the help of AI can be a huge question to the whole healthcare system in Finland, so even at a systemic level. What we found out in this piloting was actually two things. So first was on technical level, we found out that the AI technology was mature enough to be uptaken by the healthcare professionals and the organization. So we were very lucky with that, or happy with that, not lucky, but happy. The second point was that regulation was in the first place quite something which we were very, very cautious about, in the sense that is it so that we can go through all the regulatory burden that we foresaw there to be, and we were happy to notice that it is doable. So in the regulatory way, we were also on the positive side. So in that way, I think we noticed an important thing, that technology, yes, regulatory world, yes, both were on the positive side, and the healthcare counties were able to go ahead, and we were able to come up with the outcomes, which were quite according to the expectations. So we were really happy about that. But on another point, when it comes to regulation, what I am very worried about, and what is being discussed quite a lot in Finland at the moment, is that even though big organizations and the healthcare counties and perhaps big companies as well are able to cope with the regulatory burden, but when it comes to the small companies, the startups, things are very, very different for them. And now we come to the question of when we try to take AI forward in the healthcare systems, we need both parties. We need the ones who are taking it up in the operations, and the ones who are providing the solutions. We need both. So in that sense, I mean, if we are losing one key component of the system, so that creates a big problem. We actually made some calculations in Finland, which showed that when we take all the very extensive layers of regulation, meaning that GDPR, then MDR, then AI Act, the layers actually make it very difficult. And as such, each layer are quite okay, and they have good purpose, but nobody kind of has tried to optimize how to go through all these layers at the same time. And we really calculated the situation such that for a typical AI startup in Finland, it costs something like 600,000 euros just to get the first product in the market due to regulation. So one can start thinking about, is this sustainable? We have already found out in Finland that many startups are actually not looking at entering the European market because of this, but they are trying to locate and enter right away in the first place in the US market because of this. So then, I mean, Finland is losing, EU is losing, so overall the competitiveness of the EU is losing. So in this way, I just wish to say here that the Omnibus initiative is very, very welcome. And I wish that we are able to do streamline the regulation and make it easier. We need the startups in this domain. That's really a critical thing.
That's really a very important point that I have to say until now nobody had raised. So if we want to increase competitiveness, maybe we should create another type of partnerships that is business to business. And probably the best way is that big companies create their own collaborative environment with startups and foster their cross-cutting along the regulatory frameworks. But I want to go back to something that Hannah said, the human factor, because human factor is very important and is directly related to the relevance of the sociocultural context for the transformation of the digital transformation of health and care, and also the opportunities that derive in terms of new skills and new jobs, because until now we have been talking about the medicalization, finding new horizontal environments for people that should support nurses and doctors and social workers. So what do you think, Karina, in your experience about this opportunity?
Thank you so much, Maddalena. And well, I'm very happy to be here, and I will start by saying for two reasons. First, because we are the last panel, so if you are here, you are really interested. Thank you for that. We'll take that into consideration. And the second reason is because this panel is really interesting, I think, because, well, we already knew a little bit why. We already tackled different interesting aspects, but because, and here I stand not only as researcher or project manager, but also as cancer patient and advocate. What people want to know at the end is if it is implemented. This is a bit how we even started. And I was listening to you and hearing all about these wonderful technologies and thinking that somehow as people, as citizens, all of us, as patients, as caregivers, we feel somehow defrauded. I don't know if you feel the same, maybe I'm too old, but when I was a child, I heard that we will have flying cars before the end of the century, and that we would teletransport, and all of those amazing things in science fiction. And if I tell you, for example, now, that one of the hospitals where I went when I was under treatment couldn't have a system to manage appointments, and everyone had to go at the same time and wait there for the whole day, then we'll say, well, let's see, what is the missing gap here? Because we have the technology, and this, I mean, come on, managing appointments is a simple technology. It's not really difficult. We have a lot of organizational hurdles, we know. We also have all of this data aspects and also all of the industry aspects. We have the procurement, well, a lot of things that we already debated today. But what people want to know at the end is, why is this not working? What is missing here? And in this part, one of the things that perhaps complements what everyone else says is also the way that the workforce is trained and is currently still trained and considered. Well, maybe it's the same in your countries, but in Portugal right now, doctors are going through a really difficult phase. My wonderful GP has 5 minutes to talk to me, which is definitely too little. And then she has, I don't know how many hours to put things in the computer. I know this, and I empathize with her, but I want more than 5 minutes, because I have things to work with her for my health, my prevention. Oh, I'm sorry, this is a very bad word to say, prevention, because no one has time for it. And I wanted my children, and I also wanted my children to have time on this appointment, and everything is condensed. And at a certain point, maybe what we need to do, I would say, as a teaser for the rest of the panel as well, is to try to prioritize the simple things in terms of introducing digital health. Because I'm also working on amazing projects like with smart mirrors for prevention and robots and things like this, which are amazing and all of us like to discuss. But a lot of the small things that actually are maybe more focused on changing the processes and using digital and AI tools to rethink the process. This is key to have enough time to then go to the amazing AI things that we need to do. So I'm not saying these are more important than the rest, but as a person, as a citizen, as a patient, I really miss these ones. Otherwise, I need to go to the hospital at 9 a.m. to be attended at 12. And I'm not complaining personally because I live in the city, so I actually have a good hospital. I get there in 10 minutes. But in our region, for example, we have people living in the rural areas, which are 2.5 hours ago from the hospital. So, for example, during radiotherapy, they had an ambulance collecting them at their houses at 6, taking them to the hospital, and then putting them back in the house at 8 p.m. They had children. They were in usually less developed socioeconomic areas. They had usually less money. And they were away all day and had no one to take care of the house, of the kids, and etc. And this happened for consecutive days. So what happened was that actually sometimes they missed radiotherapy because of this. Do you think this is actually realistic, that it's still happening in the 21st century? I mean, I think we can do better, and I hope we can do better. So this was a bit to tease to add on all of the, let's say, high-level layers, that we still have so many small details to tackle. I hope we can do it.
You are provoking me, because I'm thinking about some regions where basically the big companies that split the data flow, the management of the data flow of the hospital, do not share the unique identifier for the patients. This means for the doctor that either him or the nurse have to enter 3 times the ID codes for the patient, because the systems are not connected, and it's impossible to make them work together. The other point is that reminds me is that we have also places where citizens have difficulties to access GPs, as you say, but because they retire. So we don't have enough GPs, and performances of the doctors are still measured in terms of number of patients they see, of procedures they make, and there is no time whatsoever to learn the new tool. So someone was referring to the not use the capacity of some tools and softwares that are available to hospital, but there is no time. If my hospital still measures me in these days, not let alone the medical school, where we have the number of beds in proportion to the students. So let's go to the next question for Petri. Finland is often seen as a model for digital health integration. So you are at the forefront. What policy and governance mechanisms have proven most effective in scaling digital nationally, and what lessons could other member states take from Finland's experience in reference to what the challenges that we just mentioned? So how did you face this in the past?
I think that's a really key question, just to begin with, and we need to, it just needs to be successful in this. Now, when it comes to AI, there was a recent report in Finland which noticed that we have more than 200 different pilots ongoing in the country, and for a small country, it's a big number, and it's kind of showing very, very openly and underlining the fact that there is lots of activity ongoing in the country. And maybe this is related to the fact, like when I was talking to one of the digital healthcare leaders from the counties about AI, and this person said that, well, for once we have a technology which we don't need to sell, meaning that there is so much of demand for this, so many positive expectations that you don't need to sell it. They are eager to take it up and start trying it out and seeing what kind of benefits might come about. So that is a good thing, and of course something that we need, and I hope that we all experience the same thing. But in Finland, I mean, we have 23 different counties responsible for healthcare, and that is of course quite a big number for a small country. These counties are very independent in their decision making in Finland, and it's very difficult to say that, although in my ideal world I would like to see that we have a national steering system which kind of makes it mandatory for each to do this and that, but this is not the thing. This is not happening in this way. And on the other side of the coin, it's of course that when they see that there is an opportunity, they go right away to the try to do something with that. So they are not expecting to have a kind of an order coming from the top and, you know, do this and do that, but they are eager to go forward. And this is the kind of situation we are facing at the moment, and there is lots of positive things about it. But then again, yes, we have tried to, and we have put in place certain kind of informal steering mechanisms at the national level, which means that all the county leaders are coming together every month. AI is one of the topics which is being discussed. The steering makes, hopefully, them see that it's good to do things commonly, and to see that the AI is one of the key things for the future to do. And overall, I think that we are doing in this domain a lot better than what we used to do in the more general kind of digital healthcare domain earlier, years ago. So it's going in a better way. There's lots of more dynamism and actually willingness to do things together, not only individually, but together. But still, I mean, having said this, still I think that there is a risk that the counties are kind of in 2 or 3 different groups, in the sense that some are the forerunners and then some are kind of observing, some are doing nothing. So in this AI domain, there is a risk of coming to a situation where we have a kind of an AI divide being happening among the counties. A crucial area where we have made national progress, and this is, I think, is really, really important for AI, is related to health data itself. In Finland, the healthcare counties started years ago in investing in data pools and in general about the data infrastructure which needs to be in place. And for a country which is quite rich in data, just to start with, we are now in a situation where not everybody does have a data pool yet, but we are getting there. So overall, the kind of infrastructure in this area is happening and coming to a point where it's there. And this is really good because, like said here today before, for AI, you need to have the data. You don't have any use of AI without data. So that is for sure something which is important. In Finland, we also have a national repository for health data called Kanta, which is quite unique internationally. We import much of the data produced in the healthcare into this one big national repository, and then it's been taken back again to the medical doctors and the patients. So that is one national big achievement that we have been able to make. That has been invested in for past 18 years. So it's a really long way that has been, taken before coming to this, but now we see that there's a huge benefit out of that. So we don't need to start getting things worked out from the scratch. Now, the last point from me for this is that we, however, still do understand that when it comes to the AI era, having all of these structures in place in Finland, it may still not be enough. And we have a review ongoing in Finland, which we started about a year ago with the Ministry of Health, which is about reviewing what kind of changes would the Finnish national health data space require so that we would be AI-proof in Finland. And for one, this requires us to take the data in a more deterministic way together, either placing it physically in one place or creating a better access so that it's accessible in a federated way. But this is important since the future is in such structures where we have rich data in great numbers accessible. This is what everybody is trying to achieve, and we think this is way to go for us. We hope that we are able to follow up with an implementation roadmap to all this. Let's see about
we are
that.
watching you. So the points you raised then is, first of all, a positive mindset. So despite you have 23 health counties, which I didn't believe you had this kind of fragmentation, if you allow me, you have the same positive mindset towards health innovation, and this is something that helps you to overcome the organizational resistance to change. The second point is that you have been collecting data pools for many years, and this is something that you are now revising. In a strategy like Andalusia said, you need to have a digital strategy that you update constantly. So my question to Anna is, what do you think, how, from a regional standpoint, but not only for Andalusia, from your experience, what do you think Europe and international frameworks support local regional territories like Andalusia in translating the digital health strategies in tangible results for citizens? I mean, to address Karina's point.
Yeah, thank you, Maddalena. But before replying to your question, I would like to take you back to the late 90s when we had the first, I did the first assessment of a digital health record in one of our healthcare centers. And the doctors there, they were all men, and I was younger. They didn't want to change the pen to type into a computer that they didn't know, and at that time it was a local computer. But I have to say that although we reported in a negative way, it was the director pushing for that. So it was a strong political leadership to implement the electronic health record in Andalusia and to move forward and into a shared way. That led us to have this single access. Everybody has an identification. I think that typing is an investment, similar to the healthcare expenditure. It's not an expenditure, it's an investment. Because the time that you spend introducing data is something that is going to serve for primary use, data use, for taking care of healthcare, of the providing of healthcare, but also the potential use for the secondary use. And I can remember my father was a doctor, repeating medication and writing in the recipes, and in the prescription, now you can do that digitally, and I can access. And also for the appointments, everything became in there. So you have all the information in one place, and you can access remotely. And in fact, I'm very glad that this morning the colleagues from the Ministry of Health, from Fernando, and also, I don't remember his name, but the guy from the Ministry of Digital Transformation at the national level commented of the national repository. So I check with my mobile, because I have my digital certificate in my mobile, and I check my personal folder at the national level, the health data. And it was the health data from my medical record that I know, and it's accessible, and it's shared in a federated way from all the regions, and it's going to go to the European level. And I think what I want to say that it's possible to share data, that I can go elsewhere and share my information for taking care of my health in case I'm going to Finland or Helsinki next January, probably, or whatever. So that's a reality. So it's what European studies have to help us to provide better quality of data, follow standardization, and have an overall strategy of merging together and regulations. The same for everybody. There are many differences. We are diverse, we have different cultures. I'm from the south, people are from the north, but we all face similar needs and challenges, the aging population, the climate change, the workforce shortage everywhere, and less time for having a proper consultation with your personal family physician, that you need more time for preventive care and health promotion as well. So I think that is improving the quality, having access to your health data, and moving to common standards that overcome the diversity of cultures that is so enriching, but we need to collaborate. And I think the synergies and the bridges among the different healthcare systems under the European umbrella are very important. And also systems are evolving. We need to take care, to integrate all the different new technologies, but in a positive way, not thinking I'm taking too much time typing because I can retrieve my information later very easily. I don't have to type anything. So that what will be my vision. The support from Europe, is the collaboration from Europe at the national level, at the subnational level, and also at local level when applicable, because we are diverse, we have to collaborate.
Thank you, Anna. This is very important insights, but now that brings me to Ivan, because we know that from our experience as a regional innovation ecosystem, universities and academy are very important enabler for the transformation. But how can the collaboration between academy and industry accelerate the large-scale adoption of a digital health system? Because we know that it's the weak leg in our ecosystems. They are very hard to mobilize and commit. So,
well, first I would like to also mention the gap between the lack of infrastructure for sharing this data and this movement towards federated learning, because we want, if you cannot bring the data from the hospital to the university, then let's take the algorithm to the data. That's very nice, but you need infrastructure for that. You need high power processing computers at the hospital level. So it's not a final solution, but it can help in certain circumstances. But we should focus more on enabling data sharing in Europe. We have focused too much on preventing medical data sharing with GDPR and other stuff. Everyone shares data, too much data, on useless pursuits. For social media, we wear smartwatches, Google knows where we are, what we do, Apple knows, everyone knows. And the only thing that could be useful for us to share, medical data, no, we don't share that. And we should, whenever the consent needs to be given, we should learn from the e-commerce websites or from the platforms for, they discourage you to uncheck the data sharing. We shouldn't offer people to share data, but we should offer them to unshare, and that should be very difficult to find, because without data we will not have AI-based medicine. And even if you help people unshare data, you are going to reintroduce a major issue in AI algorithms of today, which is bias. Bias means that data set doesn't contain everything, but a selection of some data, or the data is biased in itself. So you mentioned here garbage in and then garbage out. If the data is biased, you're going to get a biased algorithm. For instance, you mentioned today is a day for HIV, remembering the day
International Day for HIV.
Exactly. So people with HIV are probably going to opt out because it's a social stigma. So in the data set, you will not have any data of any patients with HIV, and your algorithm will learn nothing of the other diseases they usually get, or do they get better or worse. So opting out of data selection is a problem if we want to get a wholesome approach, an integrated approach with proper, good algorithms that are going to be based on actual data. Now, to get back to the divide between the academia and university, and the businesses, we need first and foremost interoperability of data. As I mentioned before, as researchers, we sometimes spend 80% of the time processing the data, cleaning the data, filling in the gaps of missing data, restructuring the columns in the data set. It's gender first, age second, and then the next data set has gender and age shifted. So only 20% of actual AI machine learning. So we should focus on all those storages of medical data should follow a certain standard. So we should agree on that, whether it's going to be OMI-OP or FHIR, whatever, a standard that everyone is going to use so that when you give up the data or you sell the data or whatever you do, the one that gets it can easily utilize the algorithms. And even if we talk about federated learning, it's very nice to send the algorithms where the data is, but at least the data could be pre-prepared in a standard fashion. And to bridge the gap between academia and industry, we should focus on living labs. So places where academia and businesses collaborate early on. It's not academia that should invent what to invent or l'art pour l'art research because of research. The businesses and the consumers and the patients and the doctors can come, can tell us what the issues are, and then we can start early on to jointly work on the solutions. So we need guidance early on. And that's why, for instance, I've had the pleasure of working on Digital Europe funded projects for Euro HPC or for an AI factory antenna. And in all those projects, we usually have a budget to approach the companies or hospitals to ask them what they need and to develop for them a proof of concept solution for an issue they share with us that they have. So rather than us working alone trying to figure out what they need, they should tell us and work with us along the way so that when adoption time comes, we don't have this valley of death between universities and businesses, but we should cooperate early on. And Digital Europe incentivizes this because they fund research like this. It was like that in EuroCC, it's like that in the factory antennas, in AI factories. So it is in a good direction. That's why we established business accelerators and digital innovation hubs as well, so that we start collaborating early on at the inception phase of our research, rather than at the end when we come up with something which is not near what they actually need or want.
Thank you so much, Ivan. So, Karina, for you always the most difficult question, because we have been mentioning AI divide, we have been mentioning bias for those who risk to become neglected population and hard to reach, and we have been mentioning living labs, but there is a risk that the current models of living labs can be implemented only in certain circumstances. So how can we ensure, at least help ensuring the digital health scale-up is inclusive, addressing social needs and reducing disparities across regions rather than deepening them?
Well, I have to say that I was about to start, and please allow me to start saying that, well, Ivan is a good friend for many years, so will allow me to say that. I would be jumping out of my chair about the opt-in and opt-out of data. But then he talked about the living lab, so he's forgiven, and I think we can be friends again. But everything goes a bit in conjunction, and also with what you say. I do understand, let me call it the utilitarian view of things, because it seems that we are discussing forever this need of having data and it doesn't resonate or it doesn't work. So I do understand that. Perhaps I'm too naive, or maybe a dreamer, or maybe I still have good hopes on common good, and I would like us to have people actually opting in on sharing their data because they are informed enough and they understand the benefits. I think the benefits are still not clear, and this is perhaps what impacts it somehow. Not because, of course, people in general would understand that sharing their data would help to get to more personalized medicine, et cetera. But there's this kind of suspicious still of how the data will be used and how the organizations will actually somehow hold this against them. So this is kind of a societal issue that we need to solve, all of us, starting from the people here, I would say, because this goes on the higher levels of organizations and businesses as well. And at least from our side, I would say that if we keep the good faith and not utilitarian approach, perhaps we also provide more trust. But this is, this is my piece back to you. In any case, and because of what you were saying, I do think that the living labs are one of the good examples of how to prevent inequities in several ways. On one side, depending on regions, depending on organizations, I would perhaps put the living labs, let's say, a bit more robust in terms of stakeholders from the policy side. From my experience, and for example, the Maya project, which was one reason as well for being here, which is now implementing 8 living labs for a digital health innovation. One of the key aspects is that you also include some regional or national policymakers in each lab. And this is okay, for people who manage projects, you'll say, why are you doing this to yourselves? Yeah. Yes, I know. Why? Well, because I have been seeing a lot of projects which are very ambitious on the technological side, and the Commission forgives us if we don't reach it, because they know this is necessary to boost innovation. We need to aim high, we need to provoke researchers and developers to reach higher. But then when we talk about KPIs of engaging people and policymakers, etc., we all feel a bit afraid because we know it will be very hard. Okay, but let us try. I mean, maybe we won't make it, but if we don't try it, then we have amazing technologies at the end with very committed people like Anna, for example, in some regions, but others where you just don't find the right connections to then make it through. So I would say policymakers are key to be there together with industry and together with the academia, because otherwise it doesn't go. And the second side, and this is really important, is the citizens and patients in general. In Maya, we have a very interesting, well, I won't call it experiment because it doesn't sound good, but a pilot test, let's say, of having 5 patients which will be involved in all of the work packages of the project. Maybe I'm talking a bit jargon, I hope not, but in all of the activities, we will have patients being taught about research and doing research with us. And this is a bit different than usual, because usually, okay, we are already very evolved compared to FP7. We now engage patients in co-creation activities. We show them things in the lab very often and ask them how they think, how they feel, what they think. And sometimes we do pilots in real life settings. But as you were mentioning before, they are a bit controlled. It's that environment. It's not that usual that a developer will need to explain to a patient why this decision is being made now of excluding something if we are in the course of the project. So I think this is a nice tease to both sides. On one side, to researchers to understand what patients really want or think, or how do they feel about that. But on the other side as well, for people to understand a bit more how difficult it is. Because in the intersection of this, there's also this. It's very difficult for the academia to bring things to the real life. It's very difficult for companies to be able to put products in the market. And sometimes I think that we all, as citizens, not engaged in this, sometimes don't really understand this. So I do believe that if we are all more educated and we know each other better, we will then opt in on sharing our data. And that would be a good outcome.
That's a good perspective. But now I would like to ask you one last keyword. So if you were to make a wish to the European Commission at this point, which would be the next concrete steps that you would focus on from your specific perspective? So, Petri, yours is national.
My word is standardization.
Good. Thank you. Ivan.
My word is integration based on standardization.
Anna.
My word is collaboration.
And last,
And
Karina.
I would like to do like a Miss Europe and say peace to the world, but no, I will say equity.
Thank you. So just as a quick wrap up before we open the floor to the questions, if you allow us for a few minutes. First of all, we have been referring to the implementation gaps. And this is very important because we need to foster and to nurture our startups. So we need to help fill in this gap, fostering our startups and our young people go across all the line of growth as a company. We have heard how digital health strategy is important, but we need also to revise it periodically because technologies don't stay still. And then we have heard how think tanks like SITRA may be the secret to stay stable across organizational changes, because we know that policymakers change, governments change, and I think that one wish, if I could make one, would be that it should be allowed, it should be a felony that if some new politician comes up and throws away what of good was done by the previous governments and we have to reinvent the wheel. So I think that we should ensure consistency and across decision makers and ensure that the progress we make stays from one government to the other. And then the human factor, prioritize simple things, avoiding elitarian approaches. I like that reference. And let's ask for a stronger top-down commitment across organizational change, but also stronger infrastructure. So thank you, everybody. And if there is a question, some questions from the audience for the panel, I think that the organizer will forgive us. Any questions? Yes, please. Do you want to say what is your name and your organization, please?
So my name is Antonio Lines. I'm a psychiatrist. I work at Highfield Healthcare. It's a hospital in Dublin. But I've been working in digital psychiatry for a long time. I just, if I'm allowed, wanted to share a little bit of my perspective as a clinician, because I share your frustration with a lot of these tools not being adopted. I think a lot of what was said is absolutely true, but we also need to remind ourselves that if we are trying to adopt really transformational tools, we are changing clinical practice. And for that, we need to change practice guidelines. We cannot do whatever we want as doctors, so we need to follow practice guidelines. And for practice guidelines to integrate any type of new tools, those tools need to be properly validated and certified. And that's a long pathway. That's a long and costly pathway that should be absolutely be taken. But it's very similar to the pathway of drug development, which is basically would be inexistent without the private sector. And so with drug development, you have the private sector doing clinical trials in hospitals, collecting data from the patients in different nations at the hospitals, right, for drug development. But when we talk about algorithm development and bringing in the private sector to leverage information in hospital data sets, then that becomes a huge problem. Yes. So I can think of 10 projects out of the top of my mind from myself and a network of clinicians, innovators that have been validated at the pilot stage, that have shown improved outcomes, but have been kept either locally or discontinued altogether, not because we don't want to implement them, but because we need support in that route, and if we bring in the private sector, the hospital runs away, and we can use procurement, but we need to find the exact grant that matches whatever it is that we found out. So that's a very difficult situation. I would love to hear your thoughts on this.
Well, I think you would deserve an applause just for what you just said, because I share your frustration, but I would like to invite our experts to reply.
Well, in preparation of this conference, I looked into the German DIGO and the French PECAN, which are like fast track introduction of tools and technologies. So maybe that could be replicated on an EU level, so that a similar approach, once you prove that something works somewhere, you go on a fast track to actually try it globally. Like globally, I mean EU-wide.
That is a very nice and pragmatic suggestions. So, any other questions? Okay, so let's give a last round of applause to our speakers and our questions, our young clinicians.
We go, no?
Thank you, Maddalena. And thank you to our speakers for this rich and forward-looking discussion. And now, before we conclude, let me give you a quick preview of day 2 so you can plan your morning accordingly. Tomorrow's program will take place in parallel breakout sessions, each hosted by a different person and in the different room. There will be no plenary gathering here at the start of the day, so please go directly to the session of your choice according to your interests. For our online participants, please be aware that you will be randomly assigned to a different breakout room. If you'd like to change your assigned room, just let us know by an email. Tomorrow will be hands-on, fast-paced and interactive, a true from policy to practice day. And now, to put in practice un saludo especial, I will call José Martínez Osero will give us some closing remarks for this wonderful day. An applause for José.
I promise not to be painful because it's late, I know. Dear colleagues and dear friends, as we come at the end of the first day of the European Digital Health Summit, I want to thank the basics, the partners, the sponsors, and the collaborating organizations, but also the moderators, the speakers, and all the organization who has been around us supporting to do this first day. We have another day tomorrow. And really, a special thank you to our Master of Ceremony, Fernanda Freitas, who is always amazing. Across today's sessions, I think we could overall agree that Europe's digital health depends on 3 main pillars: trusted access to high-quality data, secure and scalable digital infrastructure, namely the European health data space, and a strong collaboration between all stakeholders. As I said this morning in the welcoming words, what we want with this summit is, in fact, to create a platform for networking, fostering collaboration, and business. So, before we close, I would like to explain a little bit about tomorrow. Tomorrow morning, we sit from plenary sessions to parallel sessions. You will have 2 options, and you will have, I think, 4 different sessions during the morning time. Then in the afternoon, we have prepared a session that is very special for us, that is the Latin American chapter. It will be in Spanish, but translated into English, so you can attend. And there we will explore really how Europe and Latin America can learn from each other on digital health. And it is also a good chance, a good opportunity to really start thinking on what we do well in this collaboration and what we need to improve. And please let me also thank to all of you again for being here in Madrid. Enjoy not only the summit, but also Madrid. And the people online, all the online attendees that we do not know about them, but they are there. I hope you are enjoying this summit. We have organized that with the best of our intentions. And I will also thank to the whole organizing team. You could probably only see some of them, but there are many. These are the people behind the scene that make this summit happen. And we have the teams of Digital Europe. I think most of them comes from Brussels. We have the team at UNIR, and also the Reference Site Collaborative Network. It is a real pleasure to work with all of you. You have done fantastic work during the first day, and for sure tomorrow. And I do not want to forget the Casa America. We have had also a very good collaboration with Casa America. And I think I just need to tell you that remember that we will meet again at 7:30 in the Winter Garden for the gala dinner. And something that I was talking with Maddalena, let's make the European Digital Health Summit an unforgettable experience. Thank you.
Muchas gracias. Yes, please join us for the networking gala dinner and cocktail reception, 7:30, like Jose has just told us, just outside in the beautiful Winter Garden. Please bring your badge with you, okay, for the gala dinner. Enjoy the evening, meet new partners. Let's celebrate a day that truly advanced Europe's digital health future. On my behalf, thank you so much for having me as your MC. I hope you have a great, great forum tomorrow, and see you all in the morning. Be sharp. Thank you so much. Bye-bye.